Hello and welcome to our podcast for the British Association of Urological Surgeons. My name is Angus Hotchkiss and I'm joined by
Danielle Wilkinson.
We are both final year medical students at the University of Manchester, and as part of our finals revision we thought it would be useful to share our wisdom, or lack of, with similarly hapless medical students.
So the topic we chose to speak about today is urological cancers. So we'll be covering the common renal and bladder tumours.
So in terms of learning objectives, we're going to cover epidemiology, etiology, clinical features, current guidelines and things that we sort of found useful from them, and then a brief bit about investigations and management.
Okay, so if we start off and cover the most common renal malignancies first, and then TCC can nicely transition us into bladder cancers. All right, so epidemiology. So renal cancer accounts for 2 to 3% of all malignancies, and that's with the highest incidence in the Western countries. So the most common type of renal malignancy is a renal cell carcinoma, and this originates from the proximal renal tubular epithelium. So 80% of kidney cancers in the UK are renal cell carcinoma.
So as we know, there are loads of cells in the kidney, but the main categories of renal cell carcinoma are clear cell, which make up about 3/4 of the population of tumour we're looking at, papillary, which is about 10%, and then some of the rarer ones such as chromophobe and the collecting duct carcinoma. A little bit about the etiology. So there are lots of risk factors, and these are things you need to remember to ask about in your history. So smoking's a big one, of course, obesity, high blood pressure, long-term dialysis. Remember to ask that about patients with kidney disease, and then you can have hereditary ones as well. So the one you might see crop up in your exam papers is von Hippel-Lindau disease, which is an autosomal dominant condition.
How do people present? Especially students were taught to look out for the classic triad of haematuria, loin pain and a loin mass. But it's not always the case. So other presentations of renal tumours include the sort of classic cancer red flags such as fatigue, weight loss, and something that crops up in MCQs is a left-sided varicocele. And renal cancers can also present as a paraneoplastic syndrome, and that is actually found in 30% of patients.
So just talk a little bit more about the metastases. So you can get the spread of these cancerous cells, and it's most often to adjacent structures. So adrenal glands is your obvious one, and then your other GI organs, so liver, spleen, colon or pancreas. You can get local lymph node involvement too around the vena cava, and you can get sort of invasion actually into the vena cava as well. And then you can also get some spread into the adipose tissue. Another thing we thought we'd mention as well, which would be good for exams, is some sort of special chest x-ray findings, aren't they, Danny?
Yeah, so you might have heard of this before. So this is the classic cannonball Mets to the lungs. There's an image on the screen now with the x-ray. So you tend to see these round, well-defined lesions throughout both of the lung fields on a chest x-ray. Okay, so next to investigations. So basic stuff first is always a good idea, and that's basically to exclude a UTI. This is also included in the NICE guidelines. So this would involve doing a urine dip. You want to culture it, and also for sensitivity and cytology. And another test which can be done in primary care are the renal function tests, but interpret with caution, because if one kidney is doing fine, then the renal function should technically be normal, as it will be compensating. So next, again, a simple blood test for an FBC. So here what you're looking for is anemia from the haematuria or a polycythemia, as some renal tumours can produce erythropoietin, which can increase the hematocrit.
And then on to sort of imaging in your further investigations. So you do a CT scan initially, without and then with contrast. And then if they don't give you a clear diagnosis, or you want to sort of get more imaging in that sense, you can look at using MRI or ultrasound. If you think the tumour is obstructing, then you can consider an IV urogram, which will give you a better picture of that.
So finally, is just the management of renal cancer. And this, as all cancers, get referred on to a specialist, so it's not really within the remit of sort of what we'd be doing. A mix of surgery, radiotherapy and chemotherapy, or a mix of all of the above. Okay, so next on to, drum roll please. Bladder cancers! Alright, so epidemiology. So bladder cancers are the 7th most common cancer in the UK. Now that's the 4th most common in men and the 11th most common in women, with the majority of patients being over the age of 60. Now men outnumber women 3 to 1, but unfortunately there is a poorer prognosis in women.
I'll do etiology again. So we're thinking about risk factors, stuff that's really important for your history. And the biggest one really is increasing age. Danny just mentioned patients, the majority of them are over 60. Smoking is a massive one as well, so that actually increases your risk. The other thing you really don't want to miss in that history is occupational exposure. So you want to ask about, if they've worked with paints, dyes, any metal or petrol products. We had one other interesting fact that we found. Danny, can you tell us?
So, bladder cancer in developing countries. So, squamous cell carcinoma is actually related to schistosomiasis.
Well done.
Thanks. Which accounts for 80% of bladder cancers. How do people usually present? Actually, 80 to 90% of patients with bladder cancer originally presented with painless, frank haematuria. And actually, more advanced disease can cause voiding symptoms.
And then onto the guideline. So you need to divide your patients into two categories broadly at the start, so urgent and non-urgent. And then within that urgent category, these are your 2-week waits really. You need to look at people who are over 45 and then over 60. So the people over 45, they need to have sort of unexplained non-visible haematuria without a UTI, or in the second category, age over 45 again, visible haematuria that persists or is still recurring after you successfully treated a UTI. And then on to the next age group, the ages over 60, and that's still in the 2-week wait here. They need to have unexplained non-visible haematuria and either dysuria or a raised white blood cell count.
Okay, so moving on, I'm going to do a little OSCE side note. Sounds so rubbish. So there are 4 main causes of haematuria in an OSCE situation. If someone's presenting with haematuria in a history or like an emergency station, you've only really got these 4 to sort of rule out. So you've got number 1, your renal stones, classically presenting with extreme pain. And then you've got urethral trauma. So this can be from anything such as a catheter, a simple UTI, or unfortunately a renal malignancy as well.
And onto investigation, you need to urinalysis obviously of the patient, and then you want to send that off for culture and sensitivity too. And then just some bloods, so you want to do full bloods to exclude any anemia, and then some USNEs to look at the renal function, get an idea of that, and then your standard electrolytes. And then obviously when they get to urologist, if it's on a 2-week wait, for example, they'll go and have a flexible cystoscopy and likely a biopsy if they see something there.
Okay, so now I'm just going to talk about the types of bladder cancer. So transitional cell carcinoma of the bladder accounts for 90% of bladder cancers. And as these are the cells that are also present in the kidneys, it actually accounts for 10% of renal cancer as well. So because the cancer originates from the same cells, risk factors, management, etc., are all the same because it's essentially the same cancer, just in a different location.
And then a brief bit on management. So there was a lot of guidance on this that we found on NICE. With the non-invasive tumours, you broadly split it into low, intermediate, and high risk groups. So if you're low risk, and like for the other following 2 as well, everyone has a macroscopic transurethral resection, or a TUR for short. In the low-risk group, you might also get a single dose of the drug mitomycin C. And if you're in intermediate risk, you might get 6 doses of mitomycin C. If you're in the high-risk group, you might get intravesical BCG, and you're also a candidate for radical cystectomy.
So lastly is just the management. So this is, we're talking about the more invasive tumours here. So again, it's just a combination of surgery, chemo and radiotherapy, or a mix of the above. Ideally, a radical cystectomy is obviously the preferred curative treatment for a localised bladder cancer. So we just want to talk about the take-home messages.
The first thing we thought we'd mention is, haematuria, thinking about that, whether it's visible or it's not visible, what's causing it, and is this a cancer, which I guess brings us nicely into our second point.
Which is just the risk factors really, so things you want to think about in a history. And then finally, just referring people onwards. Obviously you'll have input from seniors, but for renal you'll be sending people on to a CT scan with a suspected renal cancer, and people with suspected bladder cancers will be going on to have a flexible cystoscopy.
Okay, so that does bring us to a close. Thank you very much for listening to our podcast. We hope it's been useful. Hopefully the end product isn't as disastrous as all the outtakes, even though we kept in some of those terrible sound effects. Until next time, watch this space.
Angus, I think we're going to be famous. Just think all the Instagram followers.